Quick disclaimer before you listen. The World's Okayest Medic podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Hold you up any longer. Thank you, gentlemen, for coming on. It's been a year since
Really?
the three of us got together.
Wow.
And I said we can talk about anything and wherever this discussion takes us. But I did ask you both to come on here because as you know, I can be pretty outspoken about things. But I feel like since I am but a simple paramedic, I need experts. I need experts to come on here.
Hey,
and
you
tell
teach
me
us a lot. You teach us a lot too. So,
well, thank you.
Oh, yeah.
I need experts to come on here and tell me if I'm right or wrong. And I can't think of two better experts in this particular area. So I'm not going to say any names or anything, but I did want to read a comment that was put on Facebook and that I didn't really agree with. And I wanted to put it to the expert panel here. And this came from somebody in an air medical program that is involved in this whole, like, oh, who are these cowboys on the ground giving blood? And the topic about pediatric blood administration came up, and it says, blah, blah, blah. I can perhaps share some perspective from my experience and understanding in giving blood to kids. Giving blood to kids is very high risk and is something that is not taken lightly, even in tertiary pediatric centers with very experienced pediatric EM and critical care physicians. There is a lot of physiologic nuance to the administration of blood in pediatrics, and they are at much higher risk for complications from non-cross products and just from blood products in general. While there is obviously also risk in giving blood to adults, the benefit largely outweighs that risk. If an adult that maybe didn't need blood gets it or gets more than needed, the risk exists, but is usually worth the potential benefit. My understanding is that the same does not necessarily apply for pediatrics, and the benefit may not always outweigh the risk. So there's typically a more conservative approach. Almost done, I swear. Of course, there are some black and white cases when it comes to benefit versus reward, but there are far more cases that are as gray as can be. Blah, blah, blah. So while I certainly don't think that community ALS programs should never be able to give blood to pediatric patients, I do think that it's very important for the legitimate risks to be known and understood, and the training and oversight needs to be commensurate with those risks. And I don't know that we're there just yet.
wow.
Okay, and that's based on zero evidence. Because if this person who wrote that would understand and have read the literature, then there's zero basis for what that person just said. And those people should get into a debate forum where they're not just sitting behind a typewriter and making the people feel who don't know what the literature shows. Because, saying these things, but I feel and I think, forget about that. We're in a space now where there's data, there's evidence-based data that has been published specifically on low titer, O positive, whole blood in pediatric patients, with trauma. There are now abstracts that are being presented that they're all showing the same thing. If you go from the military world into the civilian world, hospitals to EMS, it's all showing the same thing. So I would ask that person, and I don't know who the person is, let's get on a debate stage, or let's do it on a Zoom, and let's bring the data to the table. And that's how this should get settled. Mark, what do you think?
Yeah, I agree. And I have some, I prepped a little bit, Mike, with some data if you want it, or you think your listeners would benefit.
Absolutely.
That all strikes me as kind of a fear-based glass half full approach to life. Okay. As opposed to an opportunity-based glass half empty in the first case. I'd rather take a glass half full approach and say, what is the opportunity to save more lives? So addressing the fear part, you read that or you hear that and you think, oh, wow, there are lots of risks and only some super specialized PICU doc or PZM doc, by the way, both of whom you have on the podcast now, would even themselves be so cautious and hesitant about this procedure. And that's not actually true. I don't know and don't think there are additional risks or undue risks in children receiving transfusion compared to adults. Peter can address that in his own opinion and his own agency. But someone coming in to the ER where I or Peter would meet them, a child in hemorrhagic shock, what do they need? They need blood. We're not asking ourselves, is this risky? Should I be giving whole blood? Should I be giving blood at all? We're saying this child needs blood now, we're going to give it. Why then wouldn't we, understanding that children with compensated shock who become decompensated, meaning hypotensive, are at high risk of dying in the subsequent minutes, why would we not push that therapy further out into the field and address that hemorrhagic shock as early as possible before the child gets a lot sicker? So we know in trauma centers, and UPMC, where Peter trained, is one of the centers that has put out a lot of these data, that whole blood in children is associated with decreased mortality and morbidity when it's used compared to component therapy. Any blood is good when someone's bleeding. Whole blood is probably better. We're going to get the results of a randomized trial on that in the coming year, I believe. But the preliminary data suggests not only that is it safe, but it's probably better. And we also know that kids in shock die, and we need to prevent that. The number one risk of death for a pediatric patient coming into the ER is hypotension, decompensated shock. We need to treat that immediately with the treatment they need, which is blood. And so I'm not sure where all that fear and hesitance comes from, but I don't agree with it. I don't believe that there are excess complications associated with delivering blood to children with hemorrhagic shock. Peter?
Yeah. Okay. So here we go. Let's take you to JAMA 2023, JAMA Pediatrics 2023, titled "The Association of Pre-Hospital Transfusion with Mortality in Pediatric Trauma." 559 children included. 70 of them, 13%, received pre-hospital transfusions. Okay. And the conclusion is, in this study, pre-hospital transfusion was associated with lower rates of mortality compared with transfusion on arrival to the emergency department, suggesting bleeding pediatric patients may benefit from early hemostatic resuscitation. Now, Mark and I have known that for a long time, and we can go into the details of why that is.
Let me add to that one, Peter, from the same center
Yep.
real quick. So Feeney, F-E-E-N-E-Y, Katrina Morgan, Phil Spinella, Christine Leeper, all at UPMC. This is Journal of Trauma Acute Care Surgery, just 2024. They reviewed their own patients over 7 years at UPMC and looked at kids who got low titer whole blood. Increased proportions of low titer whole blood within the total blood product resuscitation was independently associated with survival among injured children. They answered the safety question in previous studies. We're not worried about that anymore. They're talking about, is this actually better? So Peter's talking about blood at all. I'm now giving you info on whole blood specifically.
And then also for the safety one, the paper is from the American Surgeon 2023. Don Jenkins, Josh Hazelton, and others are on this paper as well. And they had here, see how many patients, 90 patients. And the purpose of this paper was that whole blood is safe in pediatric patients. To quote, "Our data suggest whole blood resuscitation is safe when compared to component therapy resuscitation in the care of critically injured pediatric trauma patients." And then I have one last one, which I think is not out there yet, but I've gotten permission to talk about this. They may have presented this already, but this is a paper from Brian Eastridge and Don Jenkins, etc. And it's called "Timing Matters: Pre-Hospital versus On-Arrival Whole Blood Transfusion in Pediatric Trauma Patients." And their conclusion was, in our study, pre-hospital whole blood transfusion produced more unexpected survivors, I love that term, and improved shock physiology in pediatric trauma patients suffering from hemorrhagic shock. We suggest that whole blood provides safe, rapid hemostatic resuscitation to pediatric trauma patients, and the earlier they get it, the better. And it says at only $4,000 per additional unexpected survivor, it is a cost-effective and life-saving intervention that EMS agencies and blood suppliers nationwide should be incentivized to support. So I still haven't found the paper that says the opposite, Mike. So still looking for that.
Where did this thought come from? Because I've heard this in years past, that Well, there's a lot of extra coagulopathy in pediatrics who get blood, and Pal says the crystalloid is fine for the initial resuscitation. Where did this all come from? Because I have heard that before for years. I mean, you guys are working very hard to change the paradigm, which is phenomenal. But
Well, I don't know where that came from, but the way that I would answer the question is, and just in general, and Mark alluded to it before, um, when you have a patient who is bleeding out, and you go to a trauma surgeon and you say, "I have a patient who has massive hemorrhage, they're hypotensive, they're altered, and I brought them to the trauma bay. What would you give them?" And the answer is always blood. It's over. Well, whether the hospital is using whole blood or not, the answer is always blood or blood products, right? Um, so this question you ask about whether giving blood products to a hemorrhaging child somehow increases complications with respect to clotting, etc. I don't know where that came from. Mark, do you have any
No.
idea where that came from?
I mean, obviously, whole blood is a relatively new concept to all of us in the past 5 to 10 years. Interestingly, back when I was training, we were giving whole blood to babies after congenital heart disease surgery. That was even recognized then as the ideal product because it contained all the stuff, right? And that was super novel then. That was longer ago than I want to admit. Um, but it contains everything: the plasma, the red cells, the platelets, the fibrinogen, all the stuff you need. So I don't know where the hesitation comes from. My read, Mike, though, of your Facebook comment is any blood is potentially dangerous in the wrong hands out in the field. Is that kind of your impression as well? Not just whole blood.
any blood product? You mean that person was saying any blood products for
Correct.
children? Yes,
Correct.
correct. That's the way I took it.
Yeah. So, I
Okay,
mean, these are separate questions, really. Like blood at all, someone's bleeding to death, they're likely to die. What do we do? Just apply more diesel and get them to the trauma center faster? Or do we actually begin to treat that illness out in the field? The latter is the right answer.
So I found two sources as you were talking. One is titled "Coagulopathy is prevalent and associated with adverse outcomes in transfused pediatric trauma patients." When you read the conclusion, coagulopathy is prevalent in pediatric trauma patients ill enough to require transfusion and is strongly associated with mortality. So when you're sick and you have trauma and you're not being treated quickly enough, we know
Correct.
that you end up in DIC and you have pretty severe coagulopathy, and then you get those patients blood or blood products, and they end up having a high mortality. I don't think the assumption is that it was the blood products that killed them, right?
No,
Correct.
it was delay to effective
That's
therapy,
right.
number one. And then
Yes.
just as someone who reviews a lot of our trauma center massive transfusion cases, we never get them right. We never get the right ratio of products. So Holcomb published the 1-to-1-to-1 definitive paper. Well, it wasn't actually definitive, but it was suggesting that we should give equal ratios of products to someone who's with massive hemorrhage, right? We never get that right. And so in some ways, we may actually exacerbate coagulopathy if we're not using whole blood, which is the exact right ratio, number one. Number
Okay.
two, we used
Yeah.
to give a ton of saline. We can debate whether some saline, if you don't have blood immediately, is effective and safe, which it is. But we used to give a ton of saline, which then, in all the patients Peter mentioned, probably were worsening their coagulopathy before they even arrived.
Even more than that, I just think that some trauma patients are going to die despite our best efforts. It just sucks, but that's the honest truth. And I have read before, and I see that giving kids who need blood products, kids who get blood products have higher mortality. Well, it's because these kids are critically injured
Correct.
is the mortality. If
It's a
a
marker of
12-year-old
illness.
gets run over by 3 dump trucks in a row and they get blood products and then they die, that death was likely going to happen anyway, despite getting whole blood at the scene.
Right.
Right. But so I'm going to give you a case that we had recently at one of my agencies that goes exactly to your point and exactly to Mark's point. We had a kid, 4-year-old boy, in the back seat in a car seat. Yeah, they're on 995. They get hit from behind. Okay, they're stopped and the car didn't see them. The traffic, they stopped and he got hit from behind. That car seat ended up all the way up at the dashboard. His femur, his right femur, was snapped in half. We get there, he was already unconscious, and his heart rate was 50 going down to 40. This kid was dying. He was about to die.
Pre-arrest.
Pre-arrest, circulatory arrest, right there. And by the way, no head injury, no torso injury, no abdominal injury, a single femur fracture. That's it. My EMS captain came there and gave him 10 cc's per kilo of whole blood. The kid wakes right up and starts screaming like hell because of his broken leg. Halfway there, he starts going down again, another 10 cc's per kilo. So this kid, Mike, to your point, got into a serious car accident. He would have died, right? And if he would have gotten blood later at the trauma center, he still would have been dead. Now, should we attribute that death to the fact that he got blood? No. If he would have died, it's because he got the blood too late. In this particular case, he walked out of the hospital a week later.
Or
He walked
hopped
out of the
out.
hospital a week later. So, and then I have one more paper to show you guys. Hold on, getting excited here. This is another paper. Hold on. Here it is. So this one's in JAMA Surgery, and they looked at 2,387 injured patients who received a massive transfusion. And they said in this cohort study, the early use of cryoprecipitate was associated with lower 24-hour mortality among injured children who required massive transfusion. So again, going back to your original question, Mike, of where did this come from? We don't know, but it could just be this throwing things out there into the world, and hopefully people agree with your scare tactic.
And the idea over the past many years that we've all practiced that this is just the cost of doing business. The kids are going to arrive super sick, and then we're going to try to do our best. Whereas if they were like the patient Peter described, so let's rewind that case, Peter. He's 50, 60, maybe gets some saline, maybe gets a bump in his heart rate, but he basically is dead or in severe shock by the time he arrives. And then it takes your trauma team a little while. The average is 15 minutes to get the right access and get blood going. So then he certainly would have arrested by then. His shock state is worsened. His coagulopathy is worsened. His organ injury, let's say he had a brain injury too, that's worse. But wait a minute. You actually treated the problem at the point of injury, and you didn't allow that 15, 20, 30 minutes of shock to continue or arrest to continue, and his outcome is totally different. I think we're actually learning about physiology through our pre-hospital blood programs. We're learning that actually the minutes matter a whole lot, and that earlier the therapy is given, the better.
And Mark, we've talked about this whole thing about Syndican and the glycocalyx.
Correct.
It's very well known now that, and this is research.
This is for paramedics. You're going to have to explain this one.
Yeah. No, actually, the way I explain it is because I'm a simple-minded kind of guy. It's basically if you have a backyard and you have, you have a fence in your backyard to prevent people from coming in, right? That is Syndican. That is basically what your blood vessels have lining them on the inside to prevent things from leaving the blood vessel.
Otherwise known as the glycocalyx, right, Peter?
The glycocalyx. The glycocalyx is the fence in your backyard, right? Now, when you have trauma, when you have sepsis, when you have anaphylaxis, when you have a burn, that backyard fence falls down. Okay, the Syndican, the glycocalyx, goes away. And now what happens is that all the people around you can see into your backyard, they're coming into your backyard, and everything from inside your backyard is open to the outside world. So what happens is that little boy who got into a trauma, or that kid who's septic, or the adult who's septic, once the Syndican is completely gone, the glycocalyx is completely gone, the cells now open up, and any fluid you give is just going to pour out into the interstitium. It'll go into your brain, it'll go into your lungs, you'll have ARDS. You end up with problems that people like Mark see in the ICU days later, where on day 3, 4, 5, 6, that person is now 9 liters positive. They're on an oscillator. They have pneumothoraces because we've been, resuscitating them with the wrong fluid. And so with John Holcomb, what he's shown, and there's now a randomized controlled trial going on across the country. We have an observational trial going on here in Palm Beach County where we're giving plasma, which heals that glycocalyx. It fixes the backyard fence quicker because with just normal saline, that glycocalyx takes 7 days to replenish itself. And by that time, Mark has a patient who looks like the Michelin Man if that patient's still alive in the ICU.
Yep.
This brings up go ahead.
No, you go, Mike.
I was just going to say, this brings up a great point, because if you look at all of these studies, it seems like they all look at mortality, which is certainly important to look at. Duh.
Yes.
But it's also easy to study, and it completely leaves out morbidity. Like if my
Bingo.
9-year-old, let's say my 9-year-old gets run over by the 3 dump trucks that I talked about, and she doesn't get any pre-hospital blood. She goes to the trauma center. There's a delay in blood. She survives, thank God. But let's say she's got a completely complicated course of stay. She ends up in DIC. She ends up with ARDS, everything you described. And let's say she got blood from the Newcastle County paramedics, my hometown, who carries whole blood. And I think they use the life flow. I could be wrong.
I hope
But
so.
yeah, I hope so too. But let's say her morbidity is going to be much better. People who get really into like I was going to use a term I shouldn't use, into the weeds, into the evidence-based medicine. I think they look at the stats, which are so heavy on mortality, that they don't think about the morbidity.
I have a quick comment on that we are getting ready for our randomized controlled trial of pre-hospital plasma. We're working with John Holcomb, Dr. Sperry out of Pittsburgh, and they're going to the NIH, FDA, and they're getting ready. And Dr. Holcomb calls me and he says they want 6-month outcomes because we're looking at TBI specifically. And so to your point, it's very important to understand when you're looking at a TBI study, how is the patient doing? Not at 24 hours, not upon discharge, not at 30 days, but they want 6-month outcomes. And it's exactly for that reason, because if you're going to give a therapy, you want to make sure that you understand what's really happening to that patient compared to those who did not get the therapy in 6 months. That makes the study a lot harder, because getting outcomes at 6 months for any trial is very difficult to do.
I assume
But
they're
it's
talking about
important.
neurologic function, Peter, outcomes at 6 months.
Yes.
And
Yes.
and probably what's talked about less but is also equally as important as the psychological outcomes. Basically the PTSD that comes from a bad injury and a prolonged ICU stay is not trivial. What I was going to add, Mike, to Peter's comment on glycocalyx, which sounds like this obscure, weird, basic science topic, is still important. And yes, we can give plasma, and I hope we all will be at some point, specifically for TBI, maybe for sepsis, in an effort to fix what's broken there, the glycocalyx. But the other way to fix it is to not let it get broken in the first place, which means treating shock earlier. The longer the tissues are not perfused, the worse that problem gets, and we have to repair it. So if we can fix the shock quickly, as Peter's perfect example of his paramedics doing for the 4-year-old, then it doesn't get lost. It doesn't get damaged. You don't need a lot of repair. So the earlier we can do it, the better. And yes, if we have a saline-only approach, which we used to do in the systems I worked with and in our ERs for years, lots and lots of saline before we were finally willing to give some blood, we exacerbated that problem. So I think that's probably what your friend on Facebook is referring to, is our older approaches. And now we're seeing, no. The best way is to treat the patient with what they need immediately as soon as we arrive at the scene. And
Amen.
why that's taking so long, why the inertia against that is taking so long to counter, I don't fully understand. But obviously we've all talked about it on this podcast and on yours, Mike, and on stages and in writing that we've done for the last several years. So I think the momentum is growing, but there's still a lot to overcome.
But Mark, I mean, listen, guys, I could tell you that we've been fighting some of these things for many years. The guidelines just came out on October 22nd. There are things in there that have stayed in there because of inertia.
Correct.
There are things that'll never come out.
You mean
because of
PALS and ACLS, Peter, right?
PALS and ACLS. And um, anything in medicine, Mark, you've learned this, I've learned this. I know, Mike, you probably experienced this too, is that whenever you try to do something innovative, even if it's the right thing, even if you have the cure for cancer in your hand today, it'll take 10 years for it to become even considered to be standard of care. Case in point, double sequential defibrillation,
Yes.
dual sequential defibrillation, um, which you still have major establishments, AHA, ERC, who don't recommend it, right? So that's the fascinating part about all this stuff, is that this is kind of expected, in a sense.
Can I just say, I listened to your entire webinar about the AHA, and then I've watched these responses from people at the AHA, and I've watched a lot of apologists for the AHA with the guidelines, and it's almost like they're saying like, "Whoa, we never said don't do this. We're just saying it's not recommended." But no, like, you can do it. I said it's like when my mom used to say to me, "No, go ahead, Michael, you can do that. That's fine. I don't recommend it, but go ahead and do it." Like, you know damn well what the message is coming from the authority figure.
There's a lot of politics. Let's put it this way: there's a lot of politics involved. Um, on this Saturday, I'm playing tennis with one of our dual sequential survivors because he happens to be one of my father-in-law's good friends who dropped out on the tennis court, and my team was there.
Are you
And
going to
I'm
have a
gonna
couple defibrillators with you, Peter, at that tennis match?
I always carry one with me, but I probably should bring a second. Yeah,
Just pre-apply
but
the pads.
yeah, but listen, we had another survivor last week that we met at the station with. His name is Daryl, and like what I keep on doing, and I put it on LinkedIn, is that I keep putting these survivors on video, and those people would be dead if I mean, there's only one other option if you're in VF, or refractory VF, and you have no other option, which is you're dead. Okay, it boggles my mind that with the only other option being death, that these folks wouldn't say, give it a try, because we've seen 30 years of data, or whatever. 1994 is when the first double
Sorry.
sequential study, but 30 years of data. So going back to the initial point here of why there are people on the other side, um, at this point, if you're in healthcare and you're in medicine, it's kind of expected, unfortunately. We just have to keep pushing forward with more data, more publications, more registries, RCTs if possible. And then ultimately you'll get, the left side of the bell curve, then you'll get the middle of the bell curve, which we're kind of starting to get into now. And then ultimately you'll still have the people who will never join this mission.
It's become very widespread. It really has. It just, you guys travel the country way more than I do, or as my wife puts it, gallivanting around the country. I just went to 2 conferences in September, which is like the most I've gone away in 2 years. And my wife was like, "Now that you're done gallivanting around the country, maybe you can pick up the kids from school." So I don't know how you 2 get away with it, but I'm jealous.
It's
We have
work.
patient
It's work.
wives. We have patient wives.
Yeah, but no, I have, like, from traveling and just from interacting virtually with people from across the country, it has, and thanks to, in no small part to you guys, it has become very widespread. And it seems like it's now little pockets of resistance rather than little pockets of pro blood with the rest of the country going like, what the hell are these people doing?
Yeah.
Mike,
Listen,
what do you think when you read that Facebook post, if you had to encapsulate the politest, kindest response, that would also provide some data that might convince him or her, how would you say it now? I'm sorry, I don't agree with you for X reasons.
I would say the data is clear. As I tell people who come at me, and people who come at me are like, I have changed my mind before because people have thrown me information, and I am not you. If you guys both listen to the podcast, you've heard me come on before and say,
Yes,
"Hey,
I admire that.
I was wrong. Somebody
Yes.
sent me this. I've changed my mind." Pocus, great example. The end title is still a battle. We're going to talk about this.
We're gonna keep battling that one, but keep going.
Another time. We're going to talk about it. But I would tell this person, look at the data. Look at the data. And 2, I know that you are in this group that has this agenda. But if your child was on the side of the road and it was going to take a helicopter 15 minutes to get to her or him or whatever and give them blood products at the scene, would you want them to cancel the truck that has the blood coming and just say, well, the helicopter's got it and they've got more experience giving blood to kids? Or would you say, hey, that fire engine that's coming that's 5 minutes away, I'm good with them giving her blood? And I think I know what the answer would be.
Right. Right.
It's easy. It's one of my things, and people who know me are going to go, oh my God, you're so full of shit when I say this. But I am like kind of an empath when it comes to the pediatric patients. I can't help but put myself in their parents' shoes. You know, you just can't help doing it. And I just think that if you took all of this foot stomping and even the data out of the equation, if it was your kid, what would you want EMS to do?
Yeah.
Yes.
Well, so Mike, it's very fascinating you said that because in 2012 we felt the same way about stroke, and we took a lot of crap for it, and we ended up saying we're not taking any stroke patient to a primary stroke center. And the hospital that I worked for was very upset with me, and the CEO called me into his office, and he says, "You want the good news or the bad news?" I said, "I'll take the bad news." And he says, "We don't like what you're doing. You're bypassing our primary centers for the comprehensive centers." And I said, "Let me ask you a question.
Duh.
If it was your mother in the back of one of my ambulances, which hospital should we take her to?" And he says, "This one, the comprehensive." I said, "Thank you. You've answered my question." Now
It will.
it took many years for that to become the standard of care, but it took a long time for people to recognize that you just use the your mother rule. Go ahead.
There's I feel like going on the stroke thing. I feel like everybody gets a gold star that says stroke center now of some flavor. There's
Mhm.
a community hospital by me that I don't transport to, so my bosses can't come at me and say this. I never go to this hospital, but it is by me, and they have a stroke center designation, and I would not take my neighbor's dog, who I hate, to that hospital if they had a stroke. Like, of course you would go to a comprehensive stroke center.
Did you ever wonder why, guys, that why is it that the data coming out of those hospitals, the metrics of outcomes of those hospitals are not transparent? They're not available to you. They're not available to the community. You ever wondered why that is? So what we did in Florida, and this was all driven by EMS, we propped up the Florida Stroke Registry, which now I have a dashboard that I can look at 13 different metrics for each hospital, but I'm forbidden from showing those metrics to anybody else. But at least we got to the point where all the hospitals can see the other hospitals' metrics. They don't know which row is there is the other hospitals, but showing the data. So this hospital that's in your community, I'll guarantee you, if someone saw their outcomes, and let's just say for this example that their outcomes were really piss poor, right? Nobody at that point would tolerate them. You wouldn't tolerate them being in existence as a stroke hospital, but most places just say you attest that we have the biplane machine, we can give the TNK. Yes, we're a stroke hospital, but we have to um, have them show us what their outcomes are. And every state should do that. It should be driven by EMS. And that's really what we've tried to do here in Florida. We're doing it for resuscitation centers now. We're getting a lot of money for whole blood. The state's hopefully going to get money for the entire state. There's going to have a data component to it. So once you attach the data and the outcomes for all these topics that we're talking about, the answer becomes very clear.
It is funny you talk about this hiding data with the comprehensive stroke centers. If there's one thing that Philadelphia is world famous for trauma-wise, besides getting shot, it is scoop and run, where the police
Yes.
put the victim in the car, don't wait for EMS, and they haul ass to the closest trauma center. Sometimes they don't go to a trauma center because they don't know. But the data, if you read, would show amazing mortality increases. And one of the EMS services in the area, in the metro area, went to their police department that does scoop and run. And they, the trauma center was also part of this research with scoop and run that showed so much positive value with it. They said, hey, we do EMS in the city. We have blood products. Can we look at the outcomes? We just want to see the data. And they were told, absolutely not. You cannot see the data.
Interesting. Interesting.
Yeah.
Yep. True story.
Yeah. See, I
Hey,
think
Mike,
I think what
go ahead, Peter.
I was just gonna say that would be a nice a data project to do because it's very simple. You know, are you going to the trauma center by PD, or are you going there with an entity that actually carries the thing that the patient needs? So that would be interesting to look at to see that data.
I was going to go back to, I've been thinking a lot about this, your Facebook friend, and what motivates that kind of response.
He's not my friend, but
well, let's just
it was
call
a
him or her
friend.
your Facebook friend.
You're a genuinely nice person. My associate.
Associate. I would guess it's probably a nurse, a flight nurse who,
Paramedic, I believe.
or a paramedic who's used to
Flight.
with the way
You are
the way
right
we-
about the flight.
Yep. Who we're used to doing things the way we've always done them in the hospital. Blood is a precious resource. We have to check it 16 times and and you know, scan the barcode and be sure it's the right product for the right person. All that's true and makes sense. But now that we've shifted to emergency release, O negative ideally, or now low titer O positive whole blood, it's just a new concept. Wait, we're not doing all those checks. We just take the product out of the fridge and we give it to the patient, or out of the cooler and we give it to the patient. This doesn't fit with what we've done for years and years and years. And yet now we have, as Peter outlined, and I have as well a lot of safety data in adults and kids. We're not seeing transfusion reactions, the dreaded complication. And in fact, I don't know in any of the agencies I'm associated with, or you, Peter, out of thousands, probably now tens of thousands of transfusions, have we seen any transfusion reaction in a kid or adult? Zero. When I informally might poll these agencies. Now, that is yet to be published, but that seems to be true. Number two, a percentage, probably 10% or less, but a percentage of patients within these massive agencies are kids. And I have had the privilege of looking at those data as well. And a lot more surviving than survived before. And I'm going to be involved, I hope, soon in publishing some of those data out of one of our big metropolitan areas. Or mortality in kids who are shot, sadly, and hypotensive. So penetrating trauma plus hypotension equals well more than 50% risk of death. Most of them are surviving. In the high 90s are surviving if they weren't dead at the scene. That right there, it's not peer-reviewed science yet. I get that. It will be out in the coming year or two, we hope. But we're seeing, Peter and I just get to be on the leading edge, Peter actually more than I, leading his own ground agencies, of seeing these real-world cases and these real-world data come out. So I'd say to your colleague, hey, there's a lot more data out there than you're aware of. It's coming. There's not going to be a randomized control trial ever. Don't wait for that. If you're waiting for that, your career will be over before it happens, and it never will happen. So blood at the point of injury or close to it en route for kids who are hemorrhaging is the right thing to do, and it's saving lives, and we're already seeing it. I guess that would be the conclusion I would give. And the explanation would be we're shifting to a whole new paradigm of thinking about trauma and critical care, which is we bring blood to the patient. We don't wait until they're in the hospital or the OR. How does that sound as an explanation?
Wonderful.
I mean that's what any reasonable person would think. I 100% agree.
But yet, Peter, we can't get agencies, including some you and I know well, to even bite on starting a whole blood program. Why is that? They're waiting for more data.
Yeah, again, there are agencies who aren't doing things that they should be doing. We can talk about the simple stuff like high performance CPR. We could talk about CQI for cardiac arrest. Most agencies don't even know their numbers, let alone have a program like CodeStat or case review. So there's so many things that are obvious that people just aren't doing. But we just got to keep plugging away, guys. What can I tell you? Oh, and by the way, as you were talking about your mode of transport, either EMS or police. So it seems like my predominance of the data leans towards allowing the police or private vehicle transport over waiting for EMS transport. And there was a study that I'll send you, Journal of Trauma and Acute Care Surgery 2025, just released in September, that actually looked at 6 relevant studies. They were all either retrospective or prospective or observational. And they found that, and they recommend that police or private vehicle transport is better than waiting for EMS as adjuncts to traditional
Peter,
triage.
there's so many problems with those source studies. We probably don't have time to go into them, but go ahead.
I did a podcast on this last summer, 2
Okay.
summers ago now, and I read all of the stuff that came from the University of Pennsylvania. What are they going to do? Send a hitman to my house? Like, get in line. And if you read the papers, yes, they do say that. But if you do what I always tell people to do, don't just read the abstract, read the data. You will find that the mortality benefits that they found were, to use terminology that my 14-year-old would use, they are lame AF. Like, the mortality benefit is like kind of lame. And then I think, don't quote me on this, I think there was no difference in 24-hour mortality between police and civilian.
Yeah, it's only survival to admission. It's only
Correct,
survival
Peter.
to admission.
That's
Right.
the problem. The big study that was called Coming in Hot, I believe, in Journal of Trauma in 22 showed higher survival on arrival, but not at 6 or 24 hours. And guess what their median systolic was in the field or on arrival? Sorry, their median systolic on arrival, 120. These weren't sick patients. It's a totally different population. So it's easy to read the headlines, but once you dig in and see what kind of patients your agency and others are transporting, these are super sick, hypotensive in the field patients that are not expected to survive. And yet we're seeing 90+ survival, 90+% survival. I think it's probably not an applicable study.
I would agree that you shouldn't be comparing agencies that have blood, right? The question is, if you're in a place, I don't
see.
think Philly has blood yet, right? So it's obvious if you have blood, I would agree with you. The question is, like, for example, at the Pulse shooting in Orlando, literally you could throw a rock at the trauma center.
Correct. It's 1 block.
And it was 1 block away, right? Whereas in Parkland, that never would have worked because the hospitals were freaking far away, right? I mean, the girl I was in the ambulance with, it took us 20-some minutes to get to the closer trauma center, which was not a pediatric trauma center. They just took us because, they said, just come on in because we're closer.
Also,
But in the
the street
meantime,
cop
we did a
in
lot.
Philadelphia who has adrenaline pumping through, let's say they roll up on a 6-year-old who's shot, and they have adrenaline pumping through their veins, because who wouldn't at that point? But especially a police officer who's not trained. They are probably not, with all of that cognitive overloading, going to be thinking, which are the pediatric trauma resources in the area? They're just going to know that St. Joe's is 3 blocks away.
Yeah, that's a good point.
And so
I'll give you another story. I'm not going to mention too much about the story, but where there was a child who drowned in a river. The dad pulled the kid out, and when he came out, he was in extremis. Okay, so he was idly breathing, still had a pulse, and you see everything on the body cam. And so the cops who came had 2 options, and they came on ATVs because they couldn't get their car onto the sand of this river, near the river. So what they decided to do is take the ATV. They threw the kid on the back of the ATV. They zipped him to a car, and then they got the car to the ambulance. The whole thing took a long time. It was all on video. And this kid didn't make it, right? So the question is, with everything that we're talking about, if you have the resources to do the thing, and the thing could just be basic, life support, CPR, airway, that type of thing, then you should probably do it. And I agree with you that if you're not trained to do these things, and you take someone, you just throw them in the back of the car without doing the basics of hemorrhage control, what have you, it doesn't make sense to me that you would have a better outcome. And that blood pressure of 120 sounds awfully high, which means that these people were not really that sick.
Correct.
Good stuff.
Yeah, this has gone everywhere. These are the best podcasts.
And we
Kind
haven't
of
even talked about
appropriate.
C-collars yet, Mike. We haven't talked about C-collars yet.
Bring it up.
Yeah, so the NAMSP put out a position statement. Lead author is Dr. Michael Millen, and there was a number of other authors on the paper that effectively brings a very strong argument against the use of C-collars. And the argument that is being made is that when you have any kind of spinal injury, a spinal cord injury, the reason you have the bad outcome is not because of the fact that the patient moved a little bit after the injury. A, it's from the injury itself, and then B, it's because of lack of perfusion to
Correct.
a spinal cord and therefore the brain. And so there is a growing group of EMS physicians, EM physicians who feel strongly that the C collar does more harm than good, that there's never been shown to show any benefit. And this position paper sets the stage for people to now look at it and say, my goodness, what am I going to do at my department? And my prediction that this is going to go this is going to go the way of the backboard, which took a decade to get rid of. And I'm very curious. We're going to have him on our webinar on Friday, this Friday at 11 a.m. With Ben Abo, two of the authors. And I'm curious to see what you guys think about C collars. A, should we remove them completely? B, where I would start with is educating all pre-hospital clinicians to clear the C-spine, because God knows we put C collars on people who we know don't even need them. We just slap it on them. So at least we can eliminate the C-spine, the C collar from those folks. And then the third option is what the Australians are doing. They instead use a soft collar just for comfort. So anyway, curious to hear what you guys think, but this is going to be like 2026 and beyond. You're going to start
Yeah.
hearing more people talking about it.
I mean, I
Doc
think the
Piehl, you go. I have to sign for this package for 2 seconds because my
Right
wife
ahead.
is being
Okay.
patient. So
you're
I'll
not
be
going
right back.
You're not going to hear this brilliant answer. Then come on.
I'm going to hear it from across the room, but
Okay.
keep talking.
It's a
No,
package
I
of
don't know
white
that it's
powder.
brilliant, but yeah, I think universal application, probably right, Peter, that it's not helpful, maybe harmful. I think there's a subset of severe mechanism of injury with possible something as bad as an atlanto-occipital dislocation, where I wonder in those patients, as we move them, do we do further harm? I don't know the answer to that. And so since you don't have the x-ray out in the field, how do you know? So low GCS, violent mechanism, child hit by car, for example, in those, I'd still be an advocate, and yet I don't know what the precise criteria should be for choosing. What's your opinion?
Yeah, I would say that if you have a GCS of 3 and you have potential neck injury,
Bad blunt force mechanism. Yeah.
blunt force mechanism, that there has to be a way of stabilizing the patient in
Correct.
general, and there has to be a way of stabilizing the person's head and neck if possible. And I think that, and again, I'm sure that there is kind of carve outs for those types of people. When you read this, it's very well put together. Let me tell you, they actually go all the way back to World War II, and they looked at 3,944 studies, of which they analyzed 115. And essentially and you'll see on Friday, I guarantee you, he's going to make a very strong case. And this has been a passion project of his, to the extent that he's been doing this for some time now. But I think what this is going to do, if anything, it'll open the door for a true study now, because people have been afraid for many years to actually do the comparison of collar versus no collar. But the problem is, because these severe injuries occur so infrequently,
Yes.
imagine the number of patients you'll need in these studies to actually show a difference. And the question is, can a study like that get done? It's going to take tens of millions of dollars to do it. But I think ultimately this is going to happen. A study like
I
that will
agree.
help.
I agree with you guys that low GCS, significant blunt mechanism. Sure. I in the street, being on the street, feel like an absolute idiot. And I feel bad for the patient
Yeah.
when somebody is walking around with a GCS of 15, they have a boo-boo on their head,
Yep.
and I'm putting them on this
I agree with that.
uncomfortable seat collar to take them to the hospital for no reason other than I'm gonna get yelled at if I don't put the collar on this patient.
Mike, I was in the street yesterday riding in Palm Beach County. We did exactly that. A girl got clipped by a car. She was walking,
Totally.
was minor. And we came, she's sitting up, she's texting on her phone, slap a seat collar on. And I'm
One of
thinking,
I
our
just don't want to
medics
see the pendulums. You know how many issues we have where there's a pendulum swing way to one side or the other, all or nothing. It shouldn't be all or nothing. I think the scenario you described first, Mike, or I'm remembering in a child recently severely injured GCS of 3. There's a difference between that and the patient you just described, and so we need
Yes,
to have a
very
little more
much so.
nuance and a little more nuance in who we apply it to.
Very much so. We just had a paramedic, he's fine. Last week, he was going to a hot call for, I think it was unconscious, not breathing, and he vaporized a deer on the highway going to the call.
Mm.
Ended up, he was kind of banged up, but he was like, "You are not putting a seat," not to me, but to the other medic. He's like, "You are not putting a seat collar on me. You absolutely are not putting a seat collar on me." And the first question when they rolled into the trauma bay was, "Where's the seat collar?"
right. Well, instead of the question, which is the patient oxygenating and what's their blood pressure, right? So, and Mark and I have done several of these talks where we call it resuscitation before intubation. What the authors of this position paper will tell you is that sure, they're obtunded, fine, and everything, but like if you're focusing all of your efforts on just doing that, you may
Mm-hmm.
be missing the larger point, which is that the guy's hemorrhaging and he needed blood, or you needed to get an airway or oxygenate better. That's what these authors are saying is what kills these patients ultimately. And that's a very important point that
You mean
we may
being
have to
distracted
refocus.
by unnecessary interventions
Yes,
like you call it? Yeah.
correct. And the collar that ends up impeding airway, impeding blood flow. Um, So maybe it's not the movement at all, it's the lack of perfusion to that area. So he says that perfusion is the protection, not the C collar. Very
How
interesting.
prevalent are secondary injuries due to movement? Because I went down a rabbit hole and I found a whole lot of stuff about secondary injury, but it was perfusion, infection, and excitotoxicity. I didn't see a whole lot about movement causing. I did find a little bit, but it was excess movement during neurosurgery where they were
Yes.
actually manipulating the spine.
And they have, by the way, they have neuromonitoring in place during those, Mike, so they can detect if there's injury. So I don't think we know. It's probably less than we think, but I don't think we know.
And that theory is just not supported by any modern data that this whole movement causes
Yeah.
paralysis. So and again, that's why Mike wrote this up, because he wanted to set the record straight, him and the other authors. And I think all of us need to like really read through this. We should all hopefully come onto the webinar on Friday and ask the tough questions. And then once you do that, and if you're in a position like I am, where I run these very large departments, I can't just send out an info bowl to say we're getting rid of seat collars. I had to go on a massive campaign to get rid of backboards back in the day. And there were guys in the back of the room who just looked at me like, this guy doesn't know what the hell he's talking about. And here we are now. We don't use them at all, right? Except for the scoop to get them off the ground.
I would
Southern
say
Tennessee.
C-spine injury is similar to TBI in that we need to avoid hypoxia and hypotension. Those things are going to further exacerbate the injury, just like they do with a brain injury. To the extent we're not focused on basic resuscitation, we probably are causing harm if the collars distract from that.
And you listen, this is from the paper. For every 10 millimeters of mercury increase in MAP is a 79% higher odds of neuro
Yes,
improvement.
just like TBI.
Right. And so like in kids especially, so in kids they have something called Shiwara, spinal cord injury without radiologic abnormality. Say that 10 times fast. Shiwara. And what is
That's actually
Shiwara?
a flight medic FPC exam question.
Ah, well,
So
beautiful.
great you brought it up.
And I know it well because I missed a case like this. Why do you miss it? Because when the kid gets into the injury and he gets the actual the bones of the vertebrae, they deflect from each other and then they go right back into place. But the thing in the middle, the spinal cord, is now injured. You will not see that from a regular C-spine film. You only can see it on MRI, right? But now you have a very swollen spinal cord and you have vessels within that cord that are trying to perfuse it. But you have the edema, and now let's say that kid is hypotensive. That cord, over time, the injury will continue to get worse if you're not managing the blood pressure, you're not managing the perfusion. And so I think what Mike and the group is trying to do is really refocus everybody on the real reason people get, have increased morbidity, and not to make them so concerned about just holding C-spine and putting on a collar that ends up over your eyebrows.
Hmm.
Fascinating.
Is that Skiwara or however you said it? Is that more common in kids because of the
Yes.
giant heads and the little necks?
Yes. And they have laxer ligaments that can allow the vertebral bodies to separate under stress and then come back and appear normal on X-ray. Honestly, Peter, I haven't seen a ton in my life we've seen Skiwara, but not ones with poor neurologic outcomes. They have some neck pain. They go home in a collar. They do fine, most of them.
Right. So the kid that I missed, I'll tell you why I missed it. Okay. I'm not embarrassed to say where I screwed up. This kid, the mother had just flown in from the West Coast, from California, and she put her kid in the back seat, and she hits a tree head on. She falls asleep, hits a tree head on. She's okay. The kid seems okay, but he comes to my ED. It was midnight. He's in his car seat. So if you think about it, he's laying back on the car seat. His head is being supported by the car seat. I sent him for a C-spine film because he's looking fine. He's, mother's feeding him. Everything looks great. Do a C-spine. C-spine looks perfectly fine. What I should have done is taken the kid out of the car seat and see if the kid can support his own head.
Mm-hmm.
And because he could not have, I can tell you that, because when he came back, he couldn't. But you're right, because he ended up getting a halo. He ended up doing perfectly fine. So even though these kids get this type of injury, they end up doing well. I think the adults end up doing worse when they get C-spine injuries. But yes,
Correct.
Shiwara does happen. But luckily, and thank God for me, that I didn't end up in a lawsuit, because he ended up doing perfectly fine.
You bring up such a great point about taking the kid out of the car seat. I'm a field training officer, and all the time with kids, I find myself saying to the students, take that kid out of the car seat, look at the kid from head to toe, and take them out of the onesie. Like, yes, it's easy when they're presented all bundled up in the car seat, ready to go. You can carry them right to the ambulance and put them in. That is lovely. But I'm like, take the kid out of the car seat and assess them, unzip
Yes.
them, because how many times have you seen a kid you're like, this kid is fine fine. You lift
Yeah.
up that bluey pajama top and you're like, oh my, look at those retractions.
I'm like, been burned so many times.
Yeah.
And now I have a rule that no one leaves my emergency department asleep. And if you can walk out of the ER, you're walking out of the ER. I'll forget, this is many years ago. Thank God it wasn't my patient, but there was a patient who had a hip injury, who ended up having his femoral head was dislocated. Okay.
Wow.
They got the X-ray that was missed, and the kid's like, I can't get up, and she's like, that's sweetie, that's just your injury. You got injured. Puts the kid in a wheelchair, fills the kid out. They struggle to get the kid in the car. He's screaming and yelling and the whole thing. He comes back the next day. Yeah, his hip was out the entire time. So we got to be, you got to do the exam. There was a kid one time, a 13-year-old kid on a go-kart. He runs into a wall, and he comes in, and his right ankle is just, it's perpendicular, right? It's completely off. And the whole trauma team is there. All of us are there. and we're focused on this kid's ankle. And about an hour later, 13-year-old boy, he calls me over. He's like, "I'm really hurting." I'm like, I know the ankle. He's like, "No, no, not the ankle." He's like, "My balls." I looked. He had a hematoma the size of a grapefruit. Nobody looked because they all focused on the freaking ankle, right? So you learn, you make so many mistakes along the way, but that's how you get better.
Yeah. Well, I've kept you guys for an hour, which was the bargain. Do you guys have anything else you want to bring up or any closing things you wanted to talk about or?
I would just say, that people who are listening to your show, I know that they're high performers. You're outspoken, I'm outspoken, Mark's outspoken. And what I would love to see are more people speaking truth to power, more people asking the question why. And I vividly remember in 2015 when the guidelines came out with a really horrible suggestion of limiting the amount of fluid you give to kids in shock. And Mark and I had just met at that time, and it came from a trial called the Feast trial from sub-Saharan Africa. And I remember, like, I made videos about it, and I felt like I was the only one. Mark and I were the only ones clamoring. That guideline has stayed in there, but they added in this on the October release, little sentence that said, "Oh yeah, by the way, that paper that we included in 2015 probably doesn't relate to what's going on here." Like, in other words, we shouldn't listen to that. But they have not
10 years
removed.
later. Yeah.
Right. 10 years later, but the guideline itself is still there, which is consider giving fluids to kids who are in shock. So what I would ask everybody to do is, because like this has become rampant. Double, you look at dual sequential, you're looking at whole blood, all the things that we discussed today. It should, we should all be rising up and not doing it in an angry way, and not like the people who write these guidelines happen to be nice people. They're good people. But when they don't understand what we do in EMS, they don't understand that patients look different and their physiology is different in EMS. Um, and I'll even throw in this last topic, which is antibiotics for sepsis. We know it should be done. We've been doing it for 7 years. We just published our paper. There's an RCT out of Toronto, Sheldon Chesky's and his team, that's going to be published in Q1 of 2026 that should open the floodgates to give antibiotics for sepsis without the need for a blood culture. And I sure as hell hope that everybody who's in EMS goes and fights like hell, because your patients could be dying. There's an up to 40% mortality for septic shock. We just need to keep on doing what we're doing and don't just sit back and take it. That's all I ask of your audience, Mike. Let's not just sit down and take it, and don't depend on one or two or three people to be the fighters. We should all be standing up and asking these questions. And that's,
And
what I would hope.
question the guidelines themselves. Like, we need to dig
Yes.
into what the underlying source papers are. So, Mike, I just want to say it's a privilege to be on with both of you guys. Thank you for what you're doing on the podcast. You make me think and question my own assumptions. On some of them, I'm still right, and I still have to convince you of that. On the use of end-tidal CO2, nasal cannula end-tidal CO2 in particular with shock
Yeah,
stage.
the last few Saturdays, it's been the standard. By 11 a.m., I'm getting a Dr. Piehl text message about this.
It has become part of my Saturday morning habit to go to the gym and listen to Mike's Saturday morning coffee talk. I look forward to that, and then I do occasionally text him with some thoughts while I'm listening. But we'll address some of those things later. Thanks for giving us a platform to talk about one of our favorite topics, which is getting blood to patients who need it early in the field. And I'm happy to come back on and discuss it some more. So thanks a lot for inviting us.
Very good. Oh, the one thing I did want to bring up is before I let you go, I texted you about the that 7-year-old in the next county over who was the pedestrian struck that got the blood. It was the life flow that they gave.
All right.
The kid, peri-arrest kid, they gave the blood. The kid is alive and well. So
Minutes matter.
story.
Minutes matter, as you
Yeah.
saw in Peter's case and that one. Good to hear that.
Which actually, so it's interesting because you could have something out there in the field that people are using, let's say whole blood, that is not showing the outcomes that other people are seeing. And it could be as simple as you're not giving it quickly enough. And I know Mark won't talk about it, et cetera, but the fact that when you're giving these blood to people who are unconscious and they wake up right in front of your eyes, once you experience that and that patient walks out of the hospital and you have 90% survival rates, you start to recognize that, yes, you need the blood there, you need the blood product there, but it's you have to give it to them quickly. You have so Mark, I know that you in your life you've experienced that child that you had early in your career that actually made you go out and build a device that actually works. So Mike's story here, hopefully it gives you some solace that what you've done it matters. So thank you. I want to
Thank
thank you
you.
from on
Yeah, it's
behalf of
encouraging.
my people too. Appreciate it. Appreciate you.
Well, thank you, gents, for coming on. Let me hit stop, and don't get off just yet because you guys have to hit everything has to upload.